Ladies and gentlemen, at the outset, my sincere thanks to the organizing team for giving me this opportunity. And I think it's the disease modifying outcomes from glucose control to metabolic protection. So, disease modifying, right? So, generally, we like for the rheumatology, DMARDs, disease modifying anti rheumatic agents. So, now we are using a terminology which is giving some new concept or new understanding, so which can help in our management of type 2 diabetes. So I think UKPDS is a landmark trial which has given many insights for our day-to-day practice, what we are practicing for our management of type 2 diabetes. So and one straightforward answer, which insight which we have got from UKPDS is the 1% HbA1c reduction offers the benefit to the tune of somewhere around 18% to 30% for various microvascular complications. But what is the impact on the macrovascular? Though there was a trend of benefit, but which was not statistically significant at the end of the trial. We also know of the legacy effect. So where the UKPDS cohort has been followed up for 10 more years, where they found the benefit not only for the microvascular, but also macrovascular. What does it mean? So there was a immediate, intensive glycemic control definitely provides the benefit with respect to microvascular complications. But so macrovascular complication reduction was not seen immediately, but was seen later. So that means, so to get the benefit on the macrovascular complications, we have to wait. So that means one important thing is control is very, very important. Especially early control is very, very important. That is what we mean by legacy effect. So there is a sustained benefit of intensively treated individuals. So even after a long time also, that is the legacy effect. So bad legacy also will persist. So early aggressive glycemic control will have a positive impact on reducing the complications. But the question remains, see, we have so many armamentarium in our, so to manage our type 2 diabetes, right from metformin, sulfonylureas, with the addition of newer agents like SGLT2 inhibitors and the GLP-1 receptor agonists. So what is the agent? Does agent also or the anti-diabetic drug also has an influence apart from achieving the glycemic control? So in that context, we talk about pleomorphic benefits or the benefits of a particular agent beyond the glycemic control. So in that context, so now in the next couple of minutes, I am going to discuss on a pioglitazone, so which was way back introduced in 1999 by the FDA, which has a stormy journey. So we all heard of the ban, even in India also. For some time there was a ban on use of pioglitazone, but it was revoked. So now you'll be surprised to know, so the benefits of using a molecule, so which is otherwise really good with respect to achieving the glycemic control and beyond the glycemic control also. So I think same thing. So we have a ACCORD trial, VADT trial, advanced trial also, where in these three trials, so people have looked into tighter than tight glycemic control. Does it offer the benefit with respect to cardiovascular protection? So unfortunately, so there were more mortality in ACCORD trials. That's how it has been prematurely terminated. It's not because of the achieving because the explanation was high risk individuals for the cardiovascular events and more hypoglycemia events were there. So again, so tighter control is important, but how we achieve that tighter control also makes a difference. So overall, so to understand this, so previously there is a paradigm shift. I think we all aware on that aspect. So previously we used to look at the numbers or the HbA1c or the fasting or the postprandial glucose. Now we are moving away from the glucose control. That means along with the glucose control, it is also our focus should be on the organ protection. So that means, so apart from the A1C, so reduction in the cardiovascular events, reduction in the addressing the weight, reduction in the NAFLD or MASLD, or the decreasing the chronic kidney disease, which are the important contributors for the morbidity and the mortality in type 2 diabetes patients. Look at these guidelines, how the guidelines have changed from 2000 to 2020. So initially improve HbA1c, keep HbA1c less than 7 or as low as possible or as near normal as possible, avoiding the hypoglycemia. But look at the later part. So improve HbA1c, CV and renal outcomes as we were understanding the benefits of the SGLT2 inhibitors or the GLP-1 receptor agonists, which are the game changers in the management of type 2 diabetes, with a proven not only the glycemic control, addressing the weight and the cardiorenal benefits of these molecules. So difference like ominous octet we talk about. So SGLT2 inhibitors, GLP-1 receptor agonists, pioglitazone and the metformin. So it utilizes the cardiorenal metabolic drugs in combination. So there is a need to relook into or repurpose our pioglitazone for the benefit. So this is what is the disease modifying drugs. So if these drugs have been used early in the course of the diabetes, we may alter the progression and we may reduce the impact of diabetes on the organs. So pioglitazone might be an ideal agent to combine with SGLT2 inhibitors to reduce the cardiovascular events in patients with high risk diabetes. So I think this is one such study which has been conducted in India. So the study population included 18 years to 65 years with type 2 diabetes and who were on stable dose of metformin equal to or more than 1000 milligrams per day for at least 3 months prior to the screening with a HbA1c of more than 7.5 or less than 10%. And there were 2 treatment arms. The test product was fixed dose combination of dapagliflozin 10 mg with pioglitazone 15 mg of Eris Life Sciences. And the reference product was so concomitant administration of dapagliflozin of AstraZeneca and pioglitazone 15 milligrams of Pharma product, separately they have administered. So duration is 12 weeks, number of participants 184. Look at the statistics. Look, baseline HbA1c is similar in both the groups. HbA1c reduction at the end of 12 weeks, almost similar reduction in HbA1c, whether it's a fixed dose combination or used separately. And look at the reduction in the fasting plasma glucose, almost similar in both the groups. So even on the postprandial glucose control also. So conclusion, fixed dose combination of dapagliflozin plus pioglitazone offers good glycemic control also with no risk of hypoglycemia. We all know about the mechanism of action of SGLT2 inhibitors. Pioglitazone is a PPAR gamma agonist, which is an insulin sensitizer. So no risk of hypoglycemia when we use pioglitazone. SGLT2 inhibitors where reabsorption will be inhibited at the proximal tubule of the kidney. So again, insulin independent mechanism of action. So no risk of hypoglycemia when we use both these molecules. So FDC is non-inferior to the concomitant administration of dapagliflozin and pioglitazone in type 2 diabetes patient on monotherapy. So this is the combining the benefits like DAPA with pioglitazone combination. So HbA1c reduction, I think SGLT2 inhibitors to the tune of 0.8 to 1% and pio also up to 1%. And so there may be a synergy. So it may not be enhanced, which is expected, but maybe similar to 1 or 1.5. So, and important thing is the beta cell function. So, because SGLT2 inhibitor, fat mobilizer, increase the fat oxidation, so lipolysis, there is a weight reduction will be there. So, pioglitazone, because insulin sensitizer, there is a redistribution of the fat. So, demand, so as insulin resistance comes down, there is a decreased demand on the pancreatic beta cell. So, there is an effect on the preservation of the beta cells. So, insulin sensitivity increases and much more in the pioglitazone, even in the dapagliflozin also. So, and we all know that pioglitazone so is associated with increase in the weight and edema, so which can be negated by the addition of dapagliflozin, which has a diuretic effect. So it may have a neutral effect. So SGLT2 inhibitor use is associated with up to 3 kg weight loss, but similar weight gain is observed with the pioglitazone. By combining these two drugs, their net effect may be 0 on the weight. So it's Pio and the DAPA provides a strategic combination that balances the well benefits of the risk therapy in the type 2 diabetes. Again, on the fluid retention, just now we talked about body weight also may have a neutral effect. Blood pressure both have a effect on the lowering the blood pressure. So, and not only this, so look at the cardiovascular, cerebral and hepatic abnormalities that can be addressed with the combination of these. The risk of stroke or transient ischemic attack will be reduced. There is evidence suggesting that like there is a decreased incidence of strokes with the use of pioglitazone. And even cardiovascular, we are well aware, and there is a robust evidence with respect to dapagliflozin SGLT2 inhibitors with respect to the kidney protection and the cardiovascular protection. And even with the MASLD also. So effects on the metabolic memory. So with such a unique mechanism of action of SGLT2 inhibitor and the thiazolidinedione, that is the pioglitazone and the dapagliflozin, if we use very early in the course or in the onset, at the onset or at the diagnosis of diabetes, not only we achieve the glycemic control in a safer way, avoiding the hypoglycemia, but we are using a disease modifying which may have a positive effect on the organ protection in the long run. So this is one study which has looked into the legacy effect of hyperglycemia and early use of SGLT2 inhibitors. So this is from this study is from the Italy, so which is a like registry-based analysis of the data, approximately involving 2 lakh people. So where they have found out that newly detected type 2 diabetes with a poor control are at a higher risk of developing the CV. And if you have a good control, especially use of SGLT2 inhibitors within the 2 years of onset of the or diagnosis of the diabetes, that reduction, like cardiovascular event reduction, can be achieved. So again, the legacy effect beyond the glycemic control. So both DAPA and the PIO reverse cardiac remodeling. So these are all the beyond the glycemic benefits. Pioglitazone reduces hypertrophy, reduces the inflammation, reduces cell proliferation and fibrosis. DAPA, preload and afterload will be reduced, reducing the oxidative stress and hypertrophy and the inflammation. So again, this is a pioglitazone SGLT2 inhibitors and their combination for primary prevention of cardiovascular disease and heart failure in type 2 diabetes. This is a real world evidence where the combination had decreased MACE risk by 24%, MI by 19% and stroke risk by 28%, CV death by 11% and heart failure by 33%. So I think this is the glycemic durability slide, so which we all know, I think previously with the rosiglitazone from the ADOPT trial. So again, these are all the cardiovascular outcome trials with the pioglitazone. So again, landmark trials of the dapagliflozin with declare TIMI, DAPA-HF, CVD real and DAPA-CKD. So I think these are all the dapagliflozin and pioglitazone combination benefits with the reduction in the stroke, where DAPA may have a neutral effect, reduction for both the agents, MI, CV death, heart failure, but pioglitazone definitely we need to be cautious when we are using NIHA class 3 and class 4, where there is a chance that we may accelerate or the heart failure. And the renal disease, there is a proven benefit. So this is again looking at the NAFLD, the permission of the chair. Few more slides, sir, few more slides. So this is a pioglitazone is being like steatosis part. If you start very early, it may reduce the hepatic steatosis. Look at this maybe. So like definitely weight reduction to the tune of more than 15% is associated with reversal of steatosis, even MASH also. Hepatitis, inflammation can be reduced, but fibrosis, so F3, F4 is very difficult. So, but whereas if you start pioglitazone very early, even as per the ADA recommendation also, so you may reduce the steatosis. So this is again meta-analysis on the MASLD. So showing the benefit with improved liver histology, steatosis and inflammation and the ballooning. This is another meta-analysis, again similar benefits with respect to MASLD. So these are all literature, so which is showing the benefit of the combination. So this is the summary of the rationale of dapagliflozin with the pioglitazone. Look at the, so on the stroke incidence will be reduced, though SGLT2 inhibitors have a neutral effect, whereas myocardial infarction risk is reduced with both the agents, and cardiovascular death also will be reduced. Heart failure risk is increased, but that may negate by addition of SGLT2 inhibitors, ultimately proving it beneficial. And whereas fluid retention, weight gain, so may have a neutral effect because one nullifies the effect of the other, and a positive impact on the blood pressure reduction, HbA1c reduction, insulin sensitivity will improve, and insulin resistance will come down. So positive impact on the beta cell preservation and positive impact on the renal disease. So thank you so much.